Thank you. Let's invite Dr. Manpreet Kaur. She's Associate Professor in RP Center AIMS. She's going to take us to IOL power calculation in post-refractive surgery patients and intraop challenges.
Thank you, sir. A very good morning to all of you. I'll be tackling the post-refractive surgery cataract, no financial disclosures. So the challenges that lie with us are preoperatively accurate biometry and IOL power calculation, the choice of IOL, and addressing patient expectations. Intraoperatively, incision management in post-RK phacoemulsification, post-LASIK and PRK are relatively simple to manage. Phakic again poses intraop challenges regarding explant of the phakic. Postoperatively, fine-tuning of refractive outcomes and periodic periphery screening. So preoperative consideration, post-myopic PRK and LASIK, you have flattening of the central cornea. The posterior corneal surface is not affected, the anterior corneal surface is flattened. In post-RK, due to the incisions, you have central flattening of anterior and both posterior corneal curvature with a mid-peripheral steepening. So this is what is different about post-RK, and these are the issues which pose challenge during IOL power calculation. So why are there errors in IOL power calculation? One is the refractive index error, because the standard keratometrics index of 1.3375 is based on a constant anterior to posterior ratio. So once you have anterior curvature flattening, this ratio no longer holds true. Device error, the keratometry devices measure the paracentral region 3 to 4 mm and the central true flat K is not measured, so you get a false high keratometry. Formula error, the Virgin's formulas use keratometry to estimate the effective lens position. Post-operative anterior chamber depth after these corneal ablative procedure remains the same. However, the flatter K leads to an underestimation of the effective lens position. So which formula to use? We have a host of formulas. There are newer ones coming up every day. Now we have artificial intelligence in the mix. Earlier ones used pre-LASIK K and surgically induced refractive change. Then they were formula using the change in refraction only. Now we usually rely on formulas that use no previous data, because often when they come for cataract, we do not have the pre-refractive surgery keratometry values. So the newer formulas are quite accurate. 60 to 75% are within 0.5 diopters of the target refraction. Barrett True K, ray tracing formulas, OCT based formulas, and intraop aberrometry are the newer ones. So depending on can you measure the posterior corneal curvature or not, there are various formulas that are accurate, and these ones highlighted in yellow are the ones that do not require a prior history. Online calculators have made life very simple for us. We have post-refractive IOL calculator at ASCRS website, Barrett True K at the APSCRS and ASCRS website. Use these resources at your disposal. They are freely available. And when in doubt, when you're comparing two or more formulas, use the flattest K and the highest IOL power you get. So post-radial keratotomy, Barrett True K history has been found to be the most accurate. If no history is available, preoperative refraction is not known, Barrett True K no history and unadjusted Haigis have been found to be most accurate. So just an example of a case comparing Barrett True K and Haigis. So the power was higher with Barrett True K. So we chose the flattest keratometry, which was given by Barrett True K, and the higher IOL power. Coming to phakic IOLs, they do not really affect the IOL power calculation so much. There is a slight reduction in the ACD after phakic IOL implant does not adversely impact the power calculation. Optical biometry is of course preferred over ultrasonic methods and use the newer generation IOL power calculation formulae. Now coming to the type of phakic IOL, monofocal, toric or multifocal EDOF, because these patients, you have to understand, who underwent refractive surgery in the first place have very high expectations. They wanted spectacles off when they were 20. They expect the same when you're doing a cataract surgery. Monofocal IOLs should be preferred, of course. For myopic LASIK PRK, the LASIK PRK procedure itself induces positive spherical aberrations, so choose a IOL with negative spherical aberration, which are most of the commonly available IOLs. However, in hyperopic PRK or LASIK, the LASIK itself induces negative spherical aberration, so try to choose a zero spherical aberration IOL so that you do not add to these aberrations. toric IOL only in cases of post-radial keratotomy. For LASIK PRK you can go ahead. For post-RK, only if you have regular stable astigmatism in the central 3 mm, repeatable magnitude of astigmatism, use at least 2 different devices to measure the keratometry, and the corneal aberration profile has to be favorable. Multifocal or EDOF, please do avoid in post-radial keratotomy cases. You can put in post-LASIK PRK cases with minimal higher order aberrations and regular corneal surface. So your ray tracing aberrometry will come to the rescue to help you in decision making that can you go ahead with EDOFs and multifocals in post-LASIK PRK cases. In post-RK, it's a no. So if you have a good corneal MTF, PSF, less higher order aberration, you can go ahead with multifocal cases. Address patient expectations, always under promise and over deliver. You may have surprise even with the best of gadgets at your disposal. Intraoperative consideration. Post PRK and LASIK, of course you prefer intraoperative course is not significantly affected by the prior refractive surgery. For post-RK, the incisions, nuclear emulsification, high myopia operating in a well-feeling and breathing pupil may pose a problem. And at end of surgery, the incision management, splicing may occur. So when you look at the RK incisions, if you look at the formula 2 pi r or pi into diameter, so depending on the number of incisions, you can get the circumference of each arc segment. So as long as you have around 8 segments, you are fine in making a posterior limbal or a clear corneal incisions. Even till 16, in between 2 incisions, you have around 2.35 mm distance, so you can go ahead with a 2.2 mm incision. However, once you cross 16 incisions, 24 or 32 arc incisions, your arc distance is lesser than 2.2 and you are going to invariably transect the arc incisions. So please opt for a scleral incisions or a relatively posterior limbal so that you do not transect the incisions, because slicing is going to be challenging to manage. So just a case example of a post-RK with 16 RK incisions, we used Barrett True-K to choose the IOL par, and OCT is a useful guide to see the depth of incisions. Anything that is going full thickness, it will open up regardless of where your incision is because of the IOP changes. And I'm making the incision in between the 2 arc incisions, avoiding transection. It's a posterior limbal incision, and these were not too deep incisions. If you saw in the OCT, they went to up to 70% depth only. The surgery is more or less similar. It's just slightly challenging because these are often high myope cases. So that is the challenge, and the reflexes distortion by the arc incision sometimes makes visualization challenging. After that, it's often said that you can avoid hydrating the incisions to avoid splicing and can just suture it. Otherwise, surgery is uneventful. This is a case in which during IOL insertion, there was a splicing of arc incisions. So you have to suture perpendicular to the incision direction in order to take care of the splicing. As you can see, there is a splicing at the main incision point, and you have to suture then both the main wound and the arc incision, and as well in the post-operative period. Now with anterior chamber phakic IOL in situ, these are often rigid IOLs, the iris claw ones and the older anterior chamber ones. These ones are now discontinued, of course, but the iris claw ones are still in vogue, and you will be getting the post-ops after 20-30 years of implantation. So OCT is a useful guide to see that the critical distance between the endothelium and the phakic IOL is maintained, and you can do a phaco with a phakic IOL in situ and explant it after surgery. This obviates the need for 2 separate incision. Otherwise, if you explant it first, you are making a 5.5 incision. You have to suture it and either go via a separate incision to complete the phaco or do an ECC SICS. If you want to do a phaco and preserve a closed chamber phaco emulsification, then beneath a rigid phakic IOL is the way to go. It is challenging, of course, but the results are very gratifying and you're doing the best for the patient as well as the surgeon is also happy at having achieved only a single incision. You enlarge it after implanting the IOL, explant the phakic IOL, and a single suture does the trick. Then a posterior chamber phakic IOL is relatively easier to manage. You just have to bring the haptics into the anterior chamber, explant it via 2.8 mm incision, and you can go with a 2.8 mm sleeve and do a phaco through the same incision. It folds and comes out very easily. Not much of a challenge here as compared to the rigid phakic IOL. The rest of the phacoemulsification is uneventful. Use a hand-in-hand technique to avoid tearing these lenses because the material is very friable. Femtosecond laser-assisted cataract surgery has also been described in phakic IOLs, and post-operatively do consider a retinal screening. In post-RK cases, there may be delayed visual recovery or hyperopic shift, and light-adjustable IOLs can be done. Intraop aberrometry can help you if you get IOL surprises despite the best of calculations in some challenging cases. So to summarize, biometry is challenging, IOL power calculation, prefer monofocals, toric and regular astigmatism, avoid multifocals in post-RK. Intraoperatively, incision management is a challenge in post-RK cases, and phakic IOLs have to be tackled before you can proceed with phaco. Post-operatively, delayed visual recovery may be present. Counsel well, under promise and over deliver. Thank you for